Okay, we're all here. So let's get started with introductions. Hello, everyone. My name is Jocelyn Getchen-Kestenbaum. I'm Associate Clinical Professor of Law, and I'm going to get out of my email so no one hears that the rest of this session. Sorry about that. Associate Clinical Professor of Law at the Benjamin N. Cardozo School of Law and Director of the Cardozo Law Institute in Holocaust and Human Rights. I'm welcoming you to our fourth and final discussion of our digital dialogue series to celebrate our recent book volume and special journal issue addressing public health, mental health, human rights, and mass atrocity prevention. Today's talk is entitled Ways Forward for Public Health, Mental Health, and Mass Atrocity Prevention. Before we begin, I'd like to take this time to acknowledge that the Benjamin N. Cardozo School of Law is situated on the Lenape Island of Manhattan, Manhattan, in Lenape-Hoking, the Lenape homeland. We pay respect to Lenape peoples, past, present, and future, and their continuing presence in the homeland and throughout the Lenape diaspora. I'd also like to add that we'll be recording this webinar, and if you have any questions during the webinar or at the time for Q&A, please do send them through the Q&A feature on the bottom of your screen, and then we'll do our best to address them during the Q&A portion of the talk. The Cardozo Law Institute in Holocaust and Human Rights, also known as CLEAR, is the leading global center for the study, teaching, and promotion of human rights and atrocity prevention. We strengthen laws, norms, and institutions to prevent mass atrocities, to protect affected populations, and to rebuild societies in the wake of atrocity crimes. As a think tank, CLEAR furthers the theory and scholarship of human rights and atrocity prevention, while our action arm, the Benjamin B. Ferencz Human Rights and Atrocity Prevention Clinic, trains law students in human rights and atrocity prevention practice. This fourth and final digital dialogue series session explores our book published in August of 2021 called Public Health, Mental Health, and Mass Atrocity Prevention. Over the course of our 4 sessions, we explored the various chapters of the book through panels with many of our contributing authors. And in the chat, we're going to put a link where you can access and purchase this book. Finally, I want to give a special thanks to our panelists for joining us today, to CLEAR's program coordinator, Sam Scaller, for organizing this event, and also to the Cardozo Events Office for their support. A little about the book and the project. This multidisciplinary volume considers the role of public health and mental health policies and practices in the prevention of mass atrocity. And that includes war crimes, crimes against humanity, genocide, and the crime of aggression. It brings together diverse fields of study by global North and global South authors in diverse contexts, and it culminates in a narrative that demonstrates the state of the current fields on these intersecting themes within public health, mental health, and mass atrocity prevention spaces. And as this fourth in the series will show us, it also talks about the future potential direction in which these intersections could and possibly should go. The idea is that public health tools and frames can inform and improve atrocity prevention practice. Both of these fields are interested in preventing harms on a societal or population level. Both fields are also interested in structural and social risk factors for harm. Public health is about changing structures to reduce disease risks, while atrocity prevention looks at reducing these structural and social risk factors for preventing mass violence. Both frames care about positive deviance or resilience factors as well. What makes individuals, communities, and entire populations not fall to these harms? And how can we learn from those resilient individuals, groups, and communities? The various scholars and practitioners of this volume find that atrocity prevention has a lot to learn from public health and mental health tools and practice, and atrocity prevention fields can inform improved public health and mental health practice for prevention and for healing. Before we begin, I want to introduce our moderator for today's panel, Amy Mead. Dr. Mead is a licensed clinical psychologist, and currently holds a joint faculty appointment as a part-time lecturer in the Department of Psychiatry at Harvard Medical School and as assistant psychologist at McLean Hospital. She has been a consulting psychologist with the Auschwitz Institute for the Prevention of Genocide and Mass Atrocities, and she's interested in understanding how local and global mental health initiatives play a role in preventing mass atrocity and relapse. Dr. Mead received her PhD in clinical psychology from Clark University and completed a clinical internship and postdoctoral fellowship at McLean Hospital and Harvard Medical School. Please join me in welcoming Dr. Amy Mead.
Hi, everyone. Thank you so much, Jocelyn, for that beautiful introduction, and to Cordoza Law for hosting this panel. I am excited to engage our panelists today in a discussion. And before we begin, let me introduce each of them. I'm going to say name and title, and you can find their full bio in the chat. First is Dr. John McConnell. He's a licensed psychologist. Dr. McConnell studies peace, diversity, and social justice in a variety of contexts. He's a faculty coordinator of the Multicultural Peace and Justice Collaborative at the Diversity and Justice Coordinator for the PsyD in Clinical Psychology program at Wheaton College. John authored the chapter for our book entitled Multidisciplinary Needs and Assets Assessment for Atrocity Prevention: Values, Competencies, and Implications for Education, Training, and Collaboration. Welcome, John. Our next panelist is Dr. Throster Bjorgensen. He is the director of the Behavioral Health Partial Hospital at McLean Hospital. The director of the Behavioral Health Partial Hospital program at McLean Hospital and associate professor of psychology in the Department of Psychiatry at Harvard Medical School. In his role as co-director of psychology training at McLean Hospital and Harvard Medical School, he oversees McLean's nationally recognized APA-approved doctoral internship in clinical psychology. Prior to joining McLean from 2000 to 2008, he developed and directed the nationally recognized OCD treatment program at the Menninger Clinic. Throster is the lead author for the chapter in our book entitled Adapting a Transdiagnostic Mental Health Approach Based on Prescriptive Matching in Post-Genocide Rwanda. Welcome, Throster. And last but not least, our final panelist is Dr. Alexandros Bordos. He's a lecturer in clinical psychology at the University of Cyprus and the special advisor of Interpeace on mental health and psychosocial support for peace. Dr. Bordos investigates processes of multi-systemic resilience in conflict-affected populations and advises governments as well as intergovernmental organizations on the design of cross-sectoral public health infrastructures for mental health, social cohesion, and combatant reintegration in post-atrocity contexts. Alexandros is a co-author, along with Throster, for the chapter in our book entitled Adapting a Transdiagnostic Mental Health Approach Based on Prescriptive Matching in Post-Genocide Rwanda. So welcome, Alexandros. Welcome all of you. I'm excited to engage all of you today in a discussion about how we can best support atrocity prevention through public health, mental health initiatives. And I see a lot of common threads in your work, and I'm hoping we can discuss some of those. John, I'd like to start with you. You have done a nice job of detailing what an atrocity prevention needs and assets assessment is in your chapter, and I'm hoping you can tell us a little bit about it and how also human rights lawyers, public health workers, and mental health professionals can collaborate to conduct one.
Thank you for having me. Today I'm excited to talk to you a little bit about my chapter and some of the ideas that I've had related to atrocity prevention. So historically, atrocity prevention has been focused on identification of risks and potential ongoing atrocities through statistical methods, and so the approach that I wrote about is more of a kind of boots on the ground approach. Atrocity prevention needs and assets assessments, or what I'll call for short, community assessments, help us understand and bridge the gap between current realities in a community and what is required to promote a peaceful community. In other words, these assessments seek to reveal communities' risks for an atrocity and various strengths they have in order to overcome atrocities or prevent them altogether. And it assists us in knowing various solutions to overcoming atrocity risks by identifying the community's strengths, the change assets that they may have, and the community's readiness for change. And in the end, they help us develop potentially novel solutions to be implemented in a community. And an important part of this approach to atrocity prevention is that you're working with a community in the development and implementation of solutions so they can be much more well accepted in the community. So in my chapter, I talk about how human rights lawyers, public health workers, and mental health professionals can join together to develop these atrocity prevention needs and assets assessments by developing a committee together. Ideally, these committees should be comprised of professionals that are actually within the community of interest. So that like having a lawyer, public health workers, and mental health professionals that are actually from that community. And when they develop the what I call atrocity prevention needs and assets assessment committee, or an APNAC, once they develop these committees, hopefully then they expand to be to actual community members that are in the community to join with them and work together to understand the risks and resiliencies that the community has. It's important to have people that are actually in the community in the committee, because they're really important stakeholders in their own community, and they're going to have important insights that outsiders of the community are not going to have. And then an important part of this approach is that it's multidisciplinary, because public health workers, human rights lawyers, mental health professionals, they all have different perspectives and approaches. Historically, they've worked sort of in silos on atrocity prevention and response. And hopefully by working together, joining together, they can give each other their own discipline-specific perspectives and skills, and work together to even create new perspectives and skills that go beyond their own discipline-specific approaches.
Thank you for that. It's a useful detail. I'm wondering if you could speak a little bit within that about some of the core values and skills that you believe are helpful in conducting some of these assessments.
So obviously the world is complex and diverse. We're increasingly realizing the multicultural nature of the world through globalization and such. So I believe it's essential that when you're conducting these types of assessments, that people that are in the committee are multiculturally and social justice oriented. So for instance, in my chapter, I outline one potential core value that people might want to have, which I call principled egalitarianism. And principled egalitarianism is essentially defined as accompanying and collaborating with people in the process of liberating individuals from social injustices while holding a posture of neighborly love of diverse people. So, neighborly love meaning just that you're interested in working with others, that you have comfort, that you enjoy being around other people that are different than you. So this principled egalitarianism value engenders a sense of equal partnerships with community members that are mindful of not imposing one's own cultural values on another group of people. It requires that someone has a genuine desire to work with culturally diverse others out of care for them, celebration of their cultural values and worldviews, and an understanding that we all have a common humanity. So it's important to work together and to respect one another's cultural worldviews. So principle of egalitarianism also includes being multiculturally oriented, a multiculturally oriented individual that's humble, culturally humble, that's culturally open and curious while aware of one's own cultural limitations. So that's a kind of a core value that I propose in the chapter, but there could be other core values that people adopt in the process. It's just as important that they're multiculturally and social justice oriented in my mind, but it doesn't have to be principled egalitarianism per se. Now, there's also foundational competencies and functional competencies to conduct these types of community assessments. So the foundational competencies include public health prevention, mental health practice, human rights law and policy, multiculturalism, including awareness, knowledge, and skills, social justice theory and practice, and peace promotion theory and practice. And the functional competencies include needs and asset assessment processes, which I break down quite a bit, of course, in my chapter, which includes the pre-assessment, assessment, and post-assessment phases of how to conduct a needs assessment. There's also other functional competencies that include basic knowledge and skills of theory, evaluation methodology, and prevention practices that are used in all three disciplines approaches, and the ability to flexibly use these theory, evaluation methodology, and prevention practices in the context of various situations and cultures that the committee is working within. It's important to be flexible when you're in a cross-cultural context, because each situation is going to be unique. And then another thing that I'll just say real quick is that it's important to note that not every professional that joins one of these committees has to know everything about human rights law or everything about mental health practice and so forth, because ideally these committees should be multidisciplinary. So each member is going to bring their unique knowledge and understanding of their discipline, but it's important that the entire committee collectively has an understanding of these competencies. Yeah.
Thank you for that, John. Listening to you, it sounds like this reads a lot like a nice guideline for anyone considering creating atrocity prevention initiatives. And I love that you said that not everyone has to know everything, because it does seem like it can feel so intimidating for many folks who are just getting into this field. And I want to bring this over to Throster and Alexandros, because your work actually maps on nicely to what they're doing. Your work really maps together in addressing these guidelines. So Throster and Alexandros, just so everyone can be on the same page, the two of you have collaborated to create and implement a comprehensive mental health care initiative in the country of Rwanda in an effort to reduce the risk of genocidal reoccurrence and to build peace. And I'm wondering, Throster, if you could start, could you tell us about the behavioral health partial model of McLean and the transdiagnostic approach to mental health treatment that you were bringing to this program?
Yes, thank you, Amy and Joycelyn, for this invitation. And I'm happy to talk about my program anytime, any place. And I kind of have to start by just kind of a puzzlement and wonder to find myself in this panel at this stage, because I'm a director of a mental health program that's efficient and effective, and now we're talking about atrocity prevention and how is but the renewed interest and emphasis on mental health and how important that is quite exciting, and it's exciting to be part of that, and that's kind of where Alexandros and I have worked together. Well, about my program, it is based on McLean Hospital. It's just outside of Boston, in a cute little suburb called Belmont. And we treat quite a number of patients and annually. So when we were in person, we treated about 800 patients a year. But we are now, as many are, virtual. And in the Zoom world, we do a little bit fewer. But when I'm going to talk about the program as if we're in person, because in Rwanda it's very much in person. And that's the premise of this. So it was created as part of this Western culture of inpatient level of care where patients are struggling, they go inpatient. And then we have this classic outpatient level of care where people go maybe once a week. And there's intensive programs in between that help people kind of really focus on getting tremendous relief in a short time. That's called partial hospital. It's not a fully, so just a half partial, or people know it as a day treatment program. So we run one, that's the biggest one in Massachusetts at McLean Hospital called Behavioral Health Partial Hospital Program, or BHP. And there, half of our patients come from inpatient. They struggle tremendously and they're not ready to engage in outpatient work. So they come and work with us for about 2 weeks. And the other half come from outpatients in lieu of inpatient. They really are struggling and they're not benefiting adequately. So they come and join this intensive program. So what is this intensive program? Well, it's a 5 days a week program that people attend. And they attend up to 5 groups a day, so a total of 25 groups a week, so from, during 6-hour period in a day. And then during every hour, there's a different selection of groups they can engage in, depending on the presentation. And in that, they learn a lot of skills about how to handle mental health issues that come up. And then we have a multidisciplinary, interdisciplinary team that works with them. We have a clinical team manager that kind of leads the team and works with a psychiatrist, the program therapist, and the vocational counselors and nurses and other counselors. They work with this particular patient to provide an effective and focused care through our program. And part of this also is the integration, and what Alexandros and I talked a lot about, is the integration of assessment. How can we know that we're meeting the patient's needs? So we do a thorough assessment at the beginning, both self-report and structural diagnostic and the clinical interviews. And that scales every single day throughout the program. And at the end of the treatment program, those demonstrate that our program is quite effective in working with patients with depression and anxiety. And we have demonstrated that and written many articles about those interventions and that kind of structured, focused work. In a technical word, it's often referred to as behavior activation, one of these most effective elements in treating depression. But we offer up to 80 groups a week. So skill level groups and they're all more or less transdiagnostic. That's kind of hence the program. So we focus on kind of transdiagnostic vulnerability factors and mechanism of change. They used to be very diagnostic focused, and that's kind of the dichotomy of you either have or don't have depression. We are looking at this as more dimensional and transdiagnostic and kind of construct and a focus to mental health. And we work with the patients to really meet them where they are through this assessment protocol. And then through the treatment program, we engage with the patient and they go into interview therapy and groups and so forth and so on. And we are pretty robust in training. So we have a lot of psychology training, practicum students, psychology interns, and postdoctoral fellows. And I have to point it out that Amy Mead was, in fact, a practicum student and a psychology intern and a postdoctoral fellow and a staff at the BHP. So you know it well. And it's a vibrant community that every year we don't reinvent ourselves, but we listen to our students and we re-energize and work on the protocols. So that's the simple context of helping many patients in an effective way at McLean. That's kind of how I come. I'm the director of the program. I kind of try to stay out of the way of my clinical staff doing the work, but I create kind of a model where they can do their work, so to speak. And since we're talking about, but that's the context of why I'm here on this panel. And I would love if you ask me the next question about how come Alexandros and I are working together on this.
Thank you for teeing that up, Thruster. It was a great description. Throster, how did you and Alexandros come to work together
Oh,
on this program?
thank you for asking me that question. I don't wonder who gave you that idea to ask that question. Well, so it just teaches you in the humility and what John talked about, humility, because Alexandros and I have a dear colleague that was an intern, of course, of McLean, Georgia Paniatos, a professor at the University of Cyprus and a dear friend of Alexandros. And through her, he came to visit us in 2015 and spent a full day. And I treated him nice enough that he liked what he saw. I liked the program. And he kind of had an impression, as he told me, on him and kind of what we did. So when he had an opportunity to work with Interpeace and other stakeholders he knows more about kind of changing or enhancing or improving mental health, positive mental health within Rwanda, he actually reached out and asked me if I wanted to join, if the program was involved. And of course, one of our trainees was, of course, working with him in Cyprus. So it's all kind of, it's connected. But having access to a mental health program like this, yes, so basically, Alexander reached out to me a few years ago and said, "Are you interested in joining this effort?" And I was very humbled by that and said, "Absolutely." I have a lot of faith in what Alexander is doing and Interpeace and what has done. So the chapter that we wrote together, I would like to talk a little bit about that and then kind of what this has led to. So the chapter, of course, is an entire team approach. I think an American called it a village. You need a village to do things, and we definitely had one. So I'm the kind of lead author, and Alexandros is the senior author. But we have 3 collaborators from Cyprus, and Miria Iano is the postdoctoral fellow who did a lot of the heavy lifting at the University of Cyprus Clinical Psychology. We have 2 other postgraduate students, Anastasios Petro and Georgia Christo. They are postgraduate student at the University of Cyprus Clinical Psychology. And then we got a local resource and with an expert in the field from Rwanda is Eugene Rutambesa. He's associate professor in clinical psychology at the University of Rwanda. So this was a team that we used to write up and write about how we could do this, because we got an invitation to be part of this book kind of a little late and we had to move fast, and we wrote it together in an effective way, I thought. But it was about how would we do this if we had an opportunity? How would we think about building on what John's ideas are, and how would we kind of bring this to Rwanda, this little BHP program from the Western culture, to be sensitive to cultural issues and cultural values. And then, so all last year, that's kind of what we have done. Alexandros and his team has led that effort, and that's kind of how we work together. I think you had something that we wrote an article together also that you had some involvement in, Amy, and a few other things that led to this kind of vibrant community. But it's really a focus. Our work is focusing on the mental health within. They have this kind of 3 pillars of approach that I hope Alexandros can kind of take it over and talk a little bit about where, because the book chapter that we wrote about is all about how we should do this. If we had the opportunity, how would we do this? And then actually, as Alexandros hopefully can tell, we did this.
Thank you, Thruster. That was a great comprehensive overview of what the BHP is and how you got to know Alexandros. And Alexandros, just to pick up where Thruster had left off, because you did this was, as Thruster said, a theoretical chapter of what you were going to do, and then you actually did implement it. I'm wondering if you could speak a bit more about how this program has been implemented, but also what was pertinent about the McLean model in relation to creating this mental health initiative in Rwanda.
Thank you, Amy. And yeah, it may seem surprising that out of all the programs in the world, we reached out to Thruster and the BHP program at McLean to and develop this partnership. But there were compelling reasons. And let me backtrack a little bit and say about how we started getting involved in Rwanda. I was that it started at I was invited there as in my capacity as the special advisor of Interpeace on on mental health and psychosocial support. I was in Kigali, Rwanda, with the president of Interpeace, Mr. Scott Weber, about 3 years ago, and we were visiting with the then Minister of Health, the Honorable Diane Kashumba, and she reached out to us and said that we really need to we really need to develop a more effective public health infrastructure, especially with a view to the fact that we will have former genocide perpetrators who will be completing 20-year sentences and will be released to their home communities in the next 2 to 3 years. And this is going to be a critical moment in the history of Rwanda. Because of course former perpetrators have been released throughout the last 2 decades, but you can understand, of course, that the ones that are being released now are the ones with the longest sentences, therefore possibly the ones who were leaders, who had leading roles in the genocide. What can we do to help with that? So we then worked quite intensively with the Mental Health Directorate at the Rwanda Biomedical Center, which is basically the entity that supervises the public mental health infrastructure of Rwanda. And we did a participatory assessment of the situation along with the leadership of the mental health sector, the Psychologists Association of Rwanda, etc. And the main conclusions were that too much of the mental health work that is currently being done is in the individualized one-to-one approaches that are diagnostic and stigmatizing, and that these individualized approaches do not work well culturally do not work well for Rwandan people. Rwandans and people in sub-Saharan Africa more generally feel uncomfortable when they are put in the position of revealing their personal issues to some expert who is not a member of their community. And also it's not economically sustainable or scalable, because there are 12 psychiatrists and 500 psychologists in a country of 10 million. And in a country of 10 million where the prevalence of PTSD, some estimates have put it as high as, over the years, it peaked at more than 20% of prevalence of PTSD. So really, it's entirely unsustainable and unscalable to think about providing individualized approaches. Plus, the emphasis on pathology and diagnosis has a stigmatizing effect, and people are not utilizing the available services. So the result of that collaborative assessment was that what Rwanda needed was group-based and resilience-oriented approaches that build psychological skills for resilience in a way that does, of course, target people with mental disorders, but without necessarily making a big deal out of diagnosis, really focusing on the transdiagnostic factors that underlie psychological distress. And that's what that's when the penny dropped, as it were. And I had made the connection with the earlier visit in Rwanda, in Boston a couple of years earlier, where I had seen firsthand the BHP program, and it really made a lot of sense at that moment. And that's how we started. Yeah.
Thank you. That auspicious meeting. I'm wondering if you could update us about what has been happening since you've put the program together.
Yes. First, we wrote, of course, the book chapter was written just as the program was commencing, and it was actually an excellent opportunity along with a research paper that we also co-authored in the context of this wider project. It was an excellent opportunity to set some of the conceptual foundations for the work that we then did. Now, the program in Rwanda itself is funded by the European Union, and more recently also by the Swedish International Development Agency. And the initial funding that Interpeace had was to develop an intervention in one of the districts of Rwanda, Bugesera district, which is the district, it's the district just south of the capital, Kigali, that was amongst the hardest hit by the genocide. And we were therefore tasked by the Minister of Health to start the intervention there. And because if it could be shown to be effective there, it would be likely to work anywhere else in Rwanda. So what we did all of last year, working very closely with Throstur and with postgraduate students at my university and with colleagues at the University of Rwanda, was to go over all the protocols that are used at the BHP that cover a broad range of topics such as emotion regulation and distress tolerance, mindfulness, and several other key transdiagnostic skills that can be nurtured. So what we did is that we filtered all that, first of all, at the conceptual level, to see, working with our colleagues in Rwanda and with specialists in Rwanda, does it make sense to work on these skills in the context of Rwanda? Is this what people need in order to address the mental health and resilience needs? And actually, that process turned up some very interesting insights, which was, well, all this is great. It's great that you're working on all of these, building all of those, let's say, skills for emotional well-being, those skills that will lift people out of depression and anxiety. But because this is a context for genocide prevention, we also need to pay much more emphasis on skills for peaceful coexistence. So that took us a little bit more into the field of peace education. And then we started bringing in skills that, for instance, borrowing skills from nonviolent communication training literature, borrowing skills from pro-social development literature. So talking, for instance, about gratitude, forgiveness, tolerance of the imperfections of others, not stereotyping and separating persons from their ethnic group. So there was a lot of, so we ended up having this very interesting balance between the psychological coping skills that McLean is supporting its participants of that program, with this kind of peace education skills that are really absolutely essential in a genocide prevention context. So once we had the agenda of what skills to use, we then took it from there. We developed, I can talk a bit later about cultural adaptations and how that worked, but we developed a socio-emotional skills curriculum that is currently being integrated in prisons, in schools, and in hospitals, and it's at varying levels of readiness for implementation in all those settings. Of course, we first need to train participants before we can do that. But we also developed other variants on building on this fundamental skill set. We then wondered, along with our colleagues in Rwanda, well, okay, is it enough to just have it as a curriculum, though? I mean, what's the correct delivery for? What's the correct format for delivery here? And we realized that we needed some more persistent group therapy style format. So a group that would meet, let's say, every week for 6 months, for people who are more severely distressed and need that kind of safe space in order to gradually open up, especially in a community outpatient context. And we also needed something to, so we packaged that in a protocol that we named resilience-oriented group therapy. But it's really the same interventions, but packaged within a group therapy context. And then we also thought about how all of that can apply in a family context. So we packaged, again, the same skill set, but also including parenting skills and intergenerational dialogue skills in a protocol for multifamily healing spaces. So we're at this. So over the last 3 or 4 months, we've been very busy training local professionals. We have trained most of the clinical psychologists that are embedded in sectoral health centers in Bugesera district. Actually, along with a colleague who will be going to Rwanda again next week to begin training community volunteers and psychologists in multifamily healing spaces. So this is where we are. The program has since expanded beyond Bugesera to 5 additional districts. And there is talk to gradually scaling it up nationwide. I'm finding very often that my role is to encourage all colleagues to slow down a bit. Because I try to keep on the scientist hat, which says we need to do pilots, we need to do trials. Yeah, we should not be rushing. We should be taking it one step at a time. But scholar practitioner dialogues, collaborations are like that. Each side needs to really understand the perspective of the other side. The practitioners are always in a rush, and the scholars always care about due diligence. And it's there needs to be some there needs to be a good communication to clarify how to proceed on such issues.
Thank you for that. That's an exciting update. And it does sound like it's really taking off. And yes, you speak to that balance of trying to do due diligence to the study and the research and the assessment of it, as John was, nicely laying out too, what's necessary. And it sounds like you're bringing in all of these different people, which makes me think of John's work as well, like all of the different practitioners that are involved in the program. Sounds very multidisciplinary. Thank you. That's so exciting. And I'm wondering if we can kind of bring in a little piece of what you were talking about, Alexandros, because you were saying, I'll speak to this a little bit later, but I'd like to ask all of you if you could speak a bit more about the importance of cultural sensitivity in atrocity prevention, especially with regard to these mental health initiatives. John, I don't know if you want to start or.
Before I respond to that, I'll just say one quick thing about what Alexandros was talking about. In my chapter, I talk about using flexible methodology, and a big part of that is balancing the requirements of strict Western research methodology from a hypothetical deductive method, while also just balancing the needs of the people. And it sounds like that's kind of what you're wrestling with right now. So it's really interesting to hear you talk about that. So you were talking about cultural sensitivity, and when we talk about that, for me, I think about from a psychology or mental health perspective, that cultural competence has been long emphasized in psychology and mental health. But there are 2 major issues with cultural competence. The first is conceptual, and the second one is more practical. The first conceptual issue is that competence implies a bare minimum that somebody should obtain in cultural skills, awareness, and knowledge. And it's difficult to measure or ensure that someone has reached this bare minimum of competence. And then also it's difficult to figure out whether or not someone is, it's difficult for someone to actually achieve competence in every single culture that they may come across. And so another practical issue is that the field of mental health and psychology has excelled in training and education related to self-awareness of cultural themes, and also the knowledge of other cultures. But it's really lagged behind in terms of actually teaching and developing skills, practical skills for mental health practitioners in a cross-cultural context. So it's quite problematic if we have knowledge, but we don't really know how to act on it. And so the field, because of those 2, the practical and the conceptual issues with cultural competence, the mental health field has really been moving towards this notion of cultural humility, Cultural humility is having a accurate view of your own cultural skills and awareness. It's a belief that your cultural worldview is no better or worse than any other culture. And also, finally, a continual desire to always be improving your cultural competence or your skills. Is this notion of lifelong learning that no one ever really arrives at being a cultural expert. And through that lens, people are able to work more flexibly with another culture because you have this sense that you don't have all the answers, and you are going to work and collaborate with people in another culture or setting to be able to get the job done in a way that is more acceptable to that community. So that's why cultural humility is particularly relevant for community assessments rather than like cultural competence, because it allows somebody to figure out how to culturally accommodate or adapt various theories, interventions, prevention practices, or methodologies of how they go about doing that from a research perspective or a practice perspective. What it really helps enable the practitioners or the professionals is working with the community to develop more interventions that are more well accepted by the community, that are better understood by the community, and then ultimately are more effective because people are going to latch on to things that are consistent with their cultural worldview rather than a practitioner imposing their perspective or what they think is, what they believe that they're an expert in culturally.
Thanks, John. And you bring up a good point about the need for more training as we go forward. And I wonder, you're talking about these multidisciplinary or interdisciplinary conversations that need to occur. And I don't know if you have any ideas about how to implement those things in a pragmatic way. You could think about it. If you could speak to it at all, that would be wonderful. And
are you talking about like the cultural skills or?
Yes.
Yeah. So, one example of what I'll give real quick is one of my graduate students and I have been working alongside Native Hawaiians on one of these community assessments. And it's been stalled a little bit because of the COVID pandemic, unfortunately, with Hawaii's restrictions and things like that. But one way that we implement cultural humility is that when we met with one of our the main co-collaborator that we first started developing this project with, we were talking about, let's do a survey and kind of figure out what people believe about the community, about the potential for violence and things like that. And he was like, John, that's great for your ivory tower, but Native Hawaiians are not going to want to take this survey. What you need to do is go around and just listen to people's stories, because our culture is about oral histories and giving information through that oral history methodology. And so that's one way in which we said, you know what, we don't have all the answers here. We better actually do this in a more culturally consistent way. And that required a lot of growth for my graduate student and I in learning an oral history methodology, developing an interview that included cultural idioms and perspectives. And we really worked with our our culturally indigenous collaborator to finalize that oral history methodology. And the project takes a lot longer. you know, coming from a Western perspective, you know, it's almost like we want to get it done. Like, you know, like Alexandros was talking about, practitioners, sometimes you want to get it done. Sometimes even from a research perspective, you want to get it done because of, you know, oh, I got to get promoted and tenured and all those kinds of things that sometimes we worry about from the individual level, but it's ended up being a lot better project, a lot more meaningful. And the process in and of itself is a way that actually brings awareness and healing to the people that are telling us their stories in a way that a silly survey would have never done. So that's just one practical example of how we've gone about, you know, coming from a culturally humble perspective.
Thank you for that. That's a great example. It's so nice to hear stories and examples of how it's actually implemented from someone who's doing this kind of work. And I'll ask the same thing to the two of you, Throster and Alexandros. Throster, I don't know if you could speak a little bit about your understanding of cultural sensitivity with regard to creating mental health initiatives. And Alexandros, if you could talk a little bit about how you adapted the McLean model for the Rwandan population in terms of being culturally sensitive.
Right. Okay. Yeah, I'm happy to do that. And Alexandra gets the best examples, but I have to do the. I can try to set it up. So, to be culturally sensitive or showing humility and being humble, there are kind of key elements of psychology training and programming and core competency in so many aspects, as John spoke about. And but the premise is that we have these kind of unified human principles. For example, if you think about what is helpful for us, is we know that 8 hours of sleep and eating and dieting and all those things are you know, it's universal across culture to have a healthy diet and regular exercise and so forth and so on. There's also universal, as we understand it, about positive mental health. There are universal principles that work, but the way we implement them, you know, here in Belmont, Massachusetts, or the Western world versus in Sub-Saharan Africa are meaningfully different, but the principles are the same. So the cultural sensitivity and humility is, how can we take what we know and has been demonstrated through pretty sustained and focused scientific rigor to be effective? How can we bring that and enrich the community that we are coming to? So our work, both Alexander and I and the entire team from the get-go, was to be extremely sensitive and mindful of cultural sensitivity. And through that, for how I understand it, is to what John ended up talking about, this to be humble, to really do assessment, to ask, to explore, like you did it with your graduate student in Hawaii. We did that in Rwanda through Alexandros, both on ground and through survey. I hope Alexandros get a chance to tell you a little bit about a nifty survey that was done. But you can recognize that positive mental health cannot exist really without human rights, peace, and justice in kind of, or security. So there's the study in Rwanda has 3 pillars: social cohesion, kind of livelihood, and then mental health, which is, we are, and Alexandros and I are so involved with the mental health aspect of it. So culturally sensitive approach to mental health is literally that, to be humble, to ask, to bring, yes, your science, and bring the clinical integration. We learned, like Alexandra can talk about it, I hope I'm not going to give too much away about difference, for example, in seasons. And we used the tree of life as an example. And we learned a lot about history using stories, dance, and groups are so prevalent in Rwanda, but you can have the content delivered and adjusted culturally. So, and then the nuance and details that they are beyond the scope of this panel, but that's kind of how I understand it. Just be humble, but be mindful of the science. And then as Alessandros was saying, do pilots and ask the people, join up with the local stakeholders, which we did. We have experts in Rwanda working there for years that are part of this process, and they're giving us tremendously valuable feedback. And now I will, I'll stop because I can keep going, but that's how I understand it.
Thank you. Sounds like you believe that Alexandros, and I do too, has some really nice examples. Alexandros, I don't know if you could speak a little more to that.
I can provide some sweet examples, I would say, but and maybe I'll start with that and then go into some maybe harder to more difficult aspects here. So yeah, at the very kind of basic level, cultural sensitivity is about using the geography and the everyday life and the cosmology and the cultural idioms of the population in the protocols that you design. Yeah. So for instance, Rwanda is a very hilly country. It's one of the nicknames of Rwanda is that it's the land of 1,000 hills. It's basically a landlocked country high up in the the lowest level I think is 800 meters. So it's a country that's quite high up, and it's just hill after hill after hill. So everyone's daily life is going up and going down hills. Yeah, I mean, not many people have cars. So if you want to go and visit a friend, you have to go down a hill and up a hill. So, and life is full of walking up and down hills. So we use that in our self-compassion training module. We use the metaphor that you're walking up a hill, and you sprain your ankle. Are you going to be compassionate with yourself, to take care of yourself at that moment, or are you just keep pressing and ignore your pain? Yeah. So that was a very simple metaphor for self-compassion that everyone could resonate with. As a metaphor for mindfulness, we use looking at elephants walking near the walking. You're up at the top of a hill, and down at the plain you are seeing a herd of elephants, and they are walking by one after the other, and you can observe them, but you don't need to get stuck on the issue that there are elephants there. You can understand their shape and size, etc., and you can then let them go, and you can do the same thing with your thoughts. So cultural adaptation of metaphors, I think, was one of this issue of seasons. Actually, that was a nice one, because the students at my lab, which of course is based in Cyprus, so my postgraduate students are not in Rwanda, and some of them have been to Rwanda once, but they don't have that that everyday experience of the country. So they were trying to come up with metaphors for the different modules, and they came up with the metaphor of seasons, and as a metaphor for resilience. So you imagine that you're a tree, and in the winter your leaves fall, but it's okay because they will come back in the spring. I said it's a beautiful metaphor, but there's a catch. Rwanda is a tropical country and it doesn't have winter. You can talk about rainy season, you can talk about dry weather and rainy weather. So you can talk, for instance, about that there is a torrent, so you are a bird and you cannot fly. You can do that, and in the end, that's what we changed the metaphor to. So and you just have to be patient until it stops raining. Yeah, and that makes sense. But to say leaves don't fall in the winter in Rwanda, it doesn't work that way. So at the very basic level, this is cultural adaptation. But now going a little bit more seriously, though, there is a very critical strategic question, which is at what level do you do at what system level do you do the community adaptation? Because yes, of course, John is absolutely right. We really need to be culturally adapting everything we do, integrating with local practices, listening to, doing this participatory assessment that John's chapter so eloquently describes. But the question is, at what level of community do you do that? Because we debated a lot around this question of where do you do the cultural adaptation? Because if you're going to be doing this at every village or every town, it's kind of ultra participatory, but it's totally unpractical for developing scalable interventions. Also, you're unlikely to find that level of expertise at that level of community. So the way we interpreted community was the national level. So we worked with the national universities in Rwanda. We worked with the national public health authorities, and they became our participatory circle through which we did the cultural adaptation, then developed standardized protocols, which were then rolled out in all the districts of the country. So that is a very important practical question of where exactly you do that, because I see a lot and lots of colleagues that are doing mental health in context of emergencies. They're struggling with this issue because if you try to over customize down to the level of the village, you will end up losing out on expertise. And the final point that I wanted to make about cultural sensitivity and cultural adaptation is that we are also talking about, and Throster hinted on that before, we are also talking about a cultural adaptation to a country that is facing extreme poverty and cultural adaptation that is in a post-genocide country. Yeah, and you need to account for both of those. So the issue of poverty, how did we find it? We went there as psychologists and we said, you know, we have this really great idea for healing. You're already doing lots of healing work and, you know, we can build in socio-emotional skills and all that. And what we got back from many community stakeholders is that, you know, all this is great, but if you don't also offer livelihoods opportunities as the end point of these interventions, people will eventually regress back to psychosocial, socio-emotional, and also interpersonal distress and also interpersonal conflict. So we ended up building a whole separate livelihoods module so that graduates from the mental health programs can immediately go into those and start creating community cooperatives, for instance, farming cooperatives, local tourism initiatives, etc. And the post-genocide adaptation. It's really important to understand that, okay, I mean, maybe Rwanda might be more extreme than some other genocide contexts. I mean, even amongst genocide-affected countries, it's quite an extreme case. But what we found in Rwanda is that actually most of our psychologists are themselves genocide survivors. They have been severely traumatized. Some of us, you can be working with a psychologist who will be leading groups, who is the sole survival from a family of 10, yeah, and was a child and was the only child that managed to survive because she ran into the woods before the perpetrators could get to her. And she's leading the interventions, and you really have to be sensitive to that. You really need to be sensitive that you're working in a context of wounded healers. It's a wounded healer context. And of course, all mental health practitioners, to an extent, I mean, because all of us are carrying some of our own burden. So to an extent, all of us understand that concept, but it's quite extreme there. And you really need to think about how you're taking care of your therapists. And also, there are some issues about Western mental health that can be quite problematic, especially this kind of new third wave cognitive behavioral approaches that emphasize mindfulness and radical acceptance. There are some issues that you really need to navigate very carefully about how, you know, how does that fit in with a post-genocide situation? Because what I saw in Rwanda, and I suspect it's similar in other post-genocide contexts, is that there is very little tolerance for moral relativism. There's an expectation, there is an expectation that that truth would be guarded and protected, and actually protecting truth and protecting and maintaining a sharp division between what is morally right and what is morally wrong is an essential element of genocide prevention. Because if you don't do that, then it becomes moral relativism and, oh, so perpetrators, that's another perspective. And because in Western mental health, we do a lot of that relativism in all sorts of ways. And sometimes it can be part of developing interpersonal tolerance. It can be part of developing radical acceptance. And sometimes that, if you're not careful about how exactly you do that, it can come across as very offensive in a population that is trying to maintain these boundaries around what is true and what is morally acceptable and what is morally unacceptable. So these are some thoughts about about different levels of cultural adaptation.
Thank you. Those are all wonderful examples. And you started to get into another area that would be good to talk about, which is what are some of the challenges, right? What are some of the barriers to doing this work? And it sounds like you've already touched on a number of them, but I would imagine that there are more that you've come across. And John, you know, if you want to speak also about what some barriers you're coming across in doing multidisciplinary needs and assets assessment. And I know one of the panelists had, and we'll get to questions afterwards, but I also had this question is like, how do you handle the burnout that might be happening with some of these practitioners? I would imagine that that is a barrier, like finding and maintaining the people who can do the treatment during these really difficult and traumatic and potentially vicariously traumatic interventions. But I'll leave it open for all of you to talk about what are some of the challenges to your work, and can you speak about the difficulties and barriers that you've encountered? Did I stump you?
Forster, would you like to go first, or do you want me to go? Or?
I can be sure I can go first, because I come in as kind of the mental health person, and it was as again with the cultural humility and humbleness of joining this work. And you, Amy, and other people said this, you know, focusing on positive mental health is part of being proactive in helping reducing tension and helping working towards some kind of a meaningful approach. And within the limitation of being a psychologist, clinical psychologist, working within the field that I am, that's kind of my focus and so the barriers and the limitation of taking this and really working, I have a kind of an easy out on that. That all lands on Dr. Lordos. Alexandros Lordos takes that on with his Rwanda team. He goes to the sites and he works on a report, and we kind of brainstorm in our team meetings about how to do and address some of these issues. But that's kind of where I can speak, is that, you know, I'm a clinical psychologist trying to do good, focusing on a positive health, psychology health of my patients or my people or my clients. And that's kind of, so I can speak very little. So my answer to you, Amy, is that I am just, it's out of my league here. But then John and Alexandros, you can take it from here.
So the question about burnout, that's actually one of the barriers. I mean, because if people start to get engaged in this work and get burnt out, then we're not going to have people to do it. And so, you know, one thing I talk about in terms of social justice competencies is that not only is it important to know how to be a consultant advocate, in other words, working on behalf of other people, in addition to empowerment advocacy, which is working alongside people as you help them in their self-liberating processes. Another really important part of social justice advocacy is self-care, because you're going to get burnt out when you're constantly dealing with intergenerational trauma, social injustices, violence, and so forth. It's really a recipe for burnout if people are not taking care of themselves along the way. And one thing that I really talk about in the research lab that I co-direct along with 3 other faculty members, the Multicultural Peace and Justice Collaborative, is that this notion of self-care may be a little bit Western in the sense that, you know, maybe it's actually we care, that we need to take care of one another in this work, and to have times where we are in solidarity with one another and supporting one another in this work. So yeah, burnout can be one of the barriers to doing this work. Other barriers include lack of funding from government or NGOs. Of course, money helps promote work and can foster people being involved in this type of work. Another probably more important barrier than the lack of funding would be the lack of education and training in atrocity prevention, you know, especially in the mental health field, that's particularly new. And so we lack just basic training in how to have a prevention mindset for atrocities. There's also not every mental health professional takes a community psychology course, for instance, where they might learn the basic principles of community needs and assets assessments, and it's kind of approach thinking beyond the individual level and more at the community level. Sometimes it's not even really taught in a curriculum in psychology or mental health programs. And if it is, it's not real, often not emphasized unless you're in a community psychology doctoral program. And then another education training issue is that we don't often learn how to work interdisciplinary or multidisciplinary. I think about my own training, and it wasn't until I was on internship, my doctoral internship, learning how to work alongside psychiatrists and speech pathologists and nurses and nurse techs and those kinds of things to help patients, even at the individual level. So, we talk about working in with other teams. It's actually one of the American Psychological Association's benchmark competency for a psychologist, for instance, that we know how to work in multidisciplinary and interdisciplinary teams, but we don't take courses in how to do it. It's almost like practical learning. And so if our programs were set up in a way that we were actually teaching each other about, like some cross training. Oh, you're a psychologist, for instance, you can go and learn a little bit about what it's like to be a human rights lawyer. You can go learn a little bit about public health. And then you would have this kind of cross-disciplinary perspective that would really feed into being a multidisciplinary or interdisciplinary worker in this type of work. And so we just need more education and training programs that emphasize atrocity prevention, community assessments, and multidisciplinary work in general. And then finally, one of the other things I was thinking about is one of the barriers to this kind of work is the historical emphasis that we have on atrocity response and disaster response. We have, in the United States of America, there's FEMA, that we respond to disasters. And might I say that it seems maybe a little bit more exciting for somebody to have to respond to something that is this huge disaster and something really bad happened. And now we're going to, go feel meaningful because we're helping something that's very tangible that happened. But prevention can sometimes be very intangible. When we think about working as a psychologist, for instance, just this mindset shift to I'm working with this community or I'm working with this individual, that can actually be prevention. And prevention is intangible because it may never actually happen. So how does somebody know that we actually did it, right? So this historical emphasis on the response, in terms of how our systems are set up, but also how public health workers and mental health workers and human rights lawyers are employed. In many ways, their jobs are designed to reimburse them for response rather than prevention. I always joke with my students, there's not a CPT code or a billable code for doing social justice work in a community. You don't get paid for it. You have to do it in your free time almost. And so if we actually had jobs and career paths that were set up for primary, secondary, and tertiary prevention in all of these disciplines, then we might have a better chance at preventing atrocities altogether.
Thank you for that. When you brought up self-care, it actually harkened me back to another author in our book, Carolina Guzman. She's in chapter 6. So for the people who are wondering that same thing, she does a beautiful job of laying out how practitioners can manage burnout. And she has a multi-pronged approach. And you touch on many of the things, John. That was a great response. And Alexandros, If you could speak a little more about some of the barriers that you had also experienced in doing this kind of work.
Yeah, in some ways, of course, our program was fortunate and blessed. There has been quite good international support, and resources were made available to make this happen. So, in our case, that was not the problem. But one of the biggest obstacles that I noted was the challenge of building genuine national capacities. And genuine local capacities that can sustain and take over leadership of these efforts. I often find that while the sentiment of national, international, kind of local, global, whatever. I mean, of course, we're all local somewhere, so none of us is technically international. Yeah, we're just locals of another place, really. But we are kind of connected to cross-national thinking, and we carry that in a country as representatives, as it were, of a more holistic perspective and all that. But really, for all of that to be sustainable, it has to be locally, that whatever expertise we might carry does need to be locally transferred. And also, the expertise that is already there is something that we need to understand more deeply as well. Otherwise, we will be irrelevant and out of context. And all of this is quite difficult. It's quite difficult when, especially when doing it remotely. It's quite difficult when you try to do it via Zoom. Yeah, when the technology itself is not to be relied on at both ends. In global north Zoom calls are usually go off without a hitch, but it doesn't work that way when you try to do the same thing in other places. And it's a difficult everyday challenge just to communicate clearly. And it's difficult also to reach that point where you are really sharing epistemological assumptions, that you have that you really understand each other's conceptual models and implicit theories of change, so that you can really work together. So I think programs like the ones that we are all trying to do, I think we really need to invest a lot more time in being with each other. So, for instance, I often feel like a helicopter program designer. I fly into Rwanda 1 week every 2 months, and then I go back and do things remotely, then another week 2 months later, because of course my family and my university is in another country. And we really need to think about those issues. Are we willing to go and just become embedded somewhere, or are we willing to invite people from those contexts to spend an extended amount of time with us? Yeah, so that we really connect. Yeah, so I think that's what I would highlight. I would highlight these coordination challenges, these building genuine local and national ownership and national leadership. Yeah.
Thank you. Love you give really wonderful answers to all of that. And I'm noticing the time. We've done a great job with the discussion. We have about 12 minutes left. And I'd like to take the opportunity to open this up a bit to the questions from the audience, because we're getting a number of them. One of them actually came from one of our co-editors, Arlen Fuller, and he's asking if you could speak, if the group could speak more about societal approaches to building positive psychosocial environments. What are effective ways for communities to support the individuals, and how do those efforts pair with initiatives that focus on the individual? Go for it, Alexandros.
Yes, that's a great question, and thank you also for giving us an opportunity to speak about that aspect of the work that we've done in Rwanda. Of course, we spoke more so far about the interventions that they may be group-based, but they're actually group-based interventions that focus on individuals. So they're not really community-based societal approaches. So the resilience therapy approach that I mentioned before, it is about healing individuals that you're bringing together because you have an agenda of helping them build up their skills. But what do the genuine societal approaches look like? Well, actually, Rwanda is a very good example of that, and we didn't invent any of those. There is within the broader chapeau of the program that we're implementing, we have included an intervention called sociotherapy, which has become well established in Rwanda over the last 15 years. And it is about the basic premises that society comes together. They meet regularly every week for several months, and they talk about the history of the community. They talk about the present challenges, and they talk about their shared future and how they can make that future more livable, more sustainable. And they build on values of, they build on principles of honesty, care, mutual care, not so much self-care as mutual care, respect, and those approaches we've been doing in a separate context, not in the context of this project exactly, but we've been doing some pre-post assessments using questionnaires on some of those approaches, and what we're finding is that they actually have quite a strong effect size, both on mental health indicators such as anxiety and depression, but also on peace indicators such as tolerance and trust, and even more impressively on livelihood indicators such as owning small livestock or investing, having a saving mentality. So yeah, community-based approaches are a very important complement. And actually, in some of our conversations with the local stakeholders who have been implementing and leading the field in these community-based approaches, the consensus that we reached is that the two are complementary, because the community-based approaches, if an individual in the community is highly vulnerable, for instance, they're suffering from severe PTSD, substance abuse, aggression, severe anxiety, they are likely to be selected out or to be self-selected out of those community-based interventions. They're the ones that are less likely to turn up. And even when they do turn up, they're so wrapped up in their own difficulties that they're less likely to benefit. And what colleagues in Rwanda now do with that segment of the population is that they refer them to clinical interventions, to a psychiatrist, etc. So that's where the individual interventions that are more culturally grounded and group-based, that's where they come in and fill the gap that the societal healing type interventions do not quite cover. So there's a lot of complementarity between the two.
Thank you for that. John, did you want to also say something about that?
I'll just give one kind of anecdotal example of, in going back to the Native Hawaiian context, some of the interviews that we're doing along the way, part of the process I talked earlier about, it's actually can be healing for someone to tell us their story and give us their oral history and so forth. But part of our interview is about asking them, what do you want us to do with this information now that you've let us into your story? And a number of Native Hawaiians have talked about how they don't want these oral histories to just be in the ivory tower or locked up in a research database or something like that. That actually they want to use these clips that we're generating with them to develop a documentary so that it can increase people's awareness of the social injustices that are occurring in Hawaii, and then that feeds back into them taking ownership and developing certain policies. We're working alongside one of the Native Hawaiian lawyers that is a retired lawyer. Actually, there's two retired lawyers that are on our team, working for developing policies that would feed into the community to actually address social injustices. We talk about developing positive psychosocial environments. I think about peaceful communities, and what is required for developing peaceful communities in many ways is addressing unaddressed social injustices. Because from our perspective, social you can't have peace without having social justice. And so just developing policies in the process of even healing people in interviews while asking them what they want us to do is, I think that there's kind of an iterative nature from the individual level to developing community level interventions, like a documentary, for instance, that you know, it expands people's awareness of what is even going on, and encourages them to do something about it. You know.
Oh, I love all these examples. I'm realizing that we're kind of short on time, and I want to say thank you all, John McConnell, Alexandros Lordos, Throster Björgvinsson, for your efforts in this book, for your really important work, and for coming here today to talk to us about this and get people more excited about it. And I know I personally and others are looking forward to hearing more about your work in the future.
Thank you.
Thank you. Thank you.
Thank you to everyone. And thank you, Amy, for your excellent moderating skills today. We are so thrilled to have all of you as a part of this book. But what we really hope is that this is more a movement that we have started to bring together more multidisciplinary discussions and action and work toward the prevention of mass atrocity crimes and toward resilient communities, societies that are resistant to genocide and other mass atrocities. So thank you all so much for today's discussion. We'll post this discussion on our social media links, and we'll send to all of you so you can make sure that everyone in your channels are receiving this talk as well if they weren't able to make it today. So thank you, and we will be in touch soon. Take care.
Thank you.
Thank you.